Sure. Next speaker, very important, MICS CABG, a review of techniques and our experience. Dr. Abu Shadat Mohammad Saem Khan is a very good presenter, youngster. Welcome, Dr. Saem.
Actually, it's very difficult for me after Shuman Bhai's presentation. The total atmosphere is changed actually. Anyway, welcome to my part of this presentation. I'm starting with one of the most common questions of the world. Does size really matter? And the answer is really different from the different perspective, from the different scenario. If it's from the patient perspective and the question is regarding the size of the incision, then yes, size really matters. But when it about the surgeon's point of view, when you have to operate through a small incision, and there is question of the safety, there is a question of the quality of surgery, there is question of complete arterial revascularization, then what would be the answer? We will try to find it out. Okay, welcome you all to my part of the show, MICS CABG, a review of techniques and our experience. I'm Dr. Abu Shadat Mohammad Saem Khan, taking the advantage to being with you in the next few minutes. At first, a very brief history of MICS CABG. Actually, the form of MICS CABG, what we are seeing nowadays, it is introduced by this gentleman, Mr. Dr. Joseph T. McGinn Jr., along with another surgeon. He's an American surgeon, with another surgeon from Canada. He's Mark Rowan. So as this is a very much challenging operation, we have to select the patient very carefully, and we have to consider both the anatomical perspective, the physiological perspective, the surgical perspective as well. And from the anatomical perspective, mostly the chest anatomy with acceptable exposure to the heart is very important, and at the same time, non-atherosclerotic subclavian and femoral arteries, is because we have to consider the peripheral cannulation if needed. And the physiological perspective of the hemodynamic stability and adequate pulmonary function, as because we have to go for the single lung ventilation. And from the surgical perspective, there should be no aortic calcification or minimum aortic calcification, as because a very small portion of the ascending aorta is available for us to do the top end, and if there is calcification, there is no choice actually, so we have to be careful. A simple CT scan of the chest is very adequate to determine that. So from the McGinn and colleagues, they described the absolute contraindication of these three only: the severe pectus cavetum or other major chest wall deformities, severe pulmonary or peripheral vascular disease, emergency surgery with ongoing ischemia or hemodynamic compromise. And the others depend upon the quality of the patient and the experience of the surgeon. Now the incisional approaches is the Carpentier level classification. We all know that level 1 to level 4, and depending upon this level 1 to level 4, there are 4 categories of MICS CABG evolved. There's the MICS CABG, CAB, Port XS CABG, and TCAB. I'm not going for the details. Now the patient positioning and anatomical markers is a very popular figure from Medtronic. We all know this figure very well. Patient should be in the supine position and left shoulder should slightly elevated, that is 15 to 30 degree right lateral position. And to achieve that, a bump placed between the spine and the left scapula, right arm tucked, left arm tucked slightly posterior to facilitate the incision and the placement of the instruments, and defibrillator pads are placed. And we should have to keep in mind that we have to keep free the groin for emergency CPB and ready for any emergency sternotomy, median sternotomy. There is another picture from McGinn et al., a very good picture that demonstrates the anatomical markers as well. And some of the surgeons prefer the left arm in a swimmer's position, that hand in a Mao stand or a cross stand. Now the incision should be a 4 to 6 centimeter coronary incision in the left fifth or fourth intercostal space, depending upon the X-ray of the patient. Men usually just below the nipple and women below the breast along the inframammary crest. And we have to dissect the tissue and have to land in a space, commonly a space kyphoid. Now the linear harvesting, for linear harvesting is not very challenging if we use the correct instrument. We have to have thoracic retractor system as well as the roll track retractor system. Alternative of the roll track retractor system is the arch suspensory retractor system. We commonly use those retractor system. And with the help of this retractor system, we can harvest the lemma easily. We have to keep in mind that the whole length of the lemma may not be visualized at a time, only the mid portion is visualized well. We have to start from that and go into the kyphoid direction up to the subclavian vein. Then we can change the direction of the rotator retractor to elevate the lower portion so that the distal end up to the bifurcation can be easily visualized and can be harvested. This is the arch suspensory retractor system we commonly use. Now the proximal anastomosis is very challenging as because the exposure of the aorta is the key, and this can be achieved by a stepwise approach actually. If we follow the stepwise approach, it is not a very big deal actually, and it starts from the anesthetic management as well, as because if we maintain the CVP from 8 to 12, then we can prevent the RV outflow, RV dilatation, so that aorta will be visualized easily. We will go for the right lung ventilation. So if we keep the PEEP 10 to 12, then it will hyperinflate the right lung, that push the aorta a bit, so that is the visualization as well. And the pericardial and pericardial retraction is very important. If we take the multi-level pericardial suture and track it down to pull the superior mediastinum inferiorly and towards the incision side, then it will be helpful. And roll Lagging technique, I am not going for detail due to the time constraint. Now the distal anastomosis, the use of the octopus nerve and starfish in its position, some surgeon use. Some surgeon actually use the deep pericardial series, use of conventional stabilizer. We actually go for the conventional stabilizer. We don't use the octopus nerve or starfish, but we don't face any kind of problem with that. And some surgeon actually go for the deep pericardial series as well. This is the video of our procedure. So if we follow the right technique in a right patient, it's not a very big deal. The size of the incision is not that much of matter. These are literature review. I'm not going for detail due to the time constraint. This is the good news that our journal, our paper on the multi-vessel MICS CABG has been accepted for upcoming 23rd MICS Boston. You are all welcome. So remember two things from OC Harun. One, size doesn't matter. It's all about the technique. So thank you. Thank you very much.
Yeah. Now the floor is open for question and answering. We have 4 minutes in our hand. Any question from the audience? This is MICS CABG. Any question? I have one question. Do you use the femoral bypass in the multi-vessel CABG MICS?
Actually, we are not doing routinely the fem bypass in multi-vessel CABG. We are doing it off pump. But we prepare the groin. If there is need for emergency going to emergency CPB, we go for the fem bypass. When manipulating the heart, if we feel that the hemodynamic instability is there, we actually don't take the risk. We go for the fem bypass and do the rest of the job.
So what complication you expect that may happen to convert this cabbage to median sternotomy, or do you have an experience of conversion? Because I have the experience of conversion from MICS to median sternotomy, maybe 2 or 3 cases. Do you have any experience in cabbage?
So far, we haven't any experience of conversion till date.
Or any complication in the post-operative within 30 days after the MICS cabbage in comparison to the median sternotomy cabbage?
Not that much, only the few wound complications, and when we have to go for the fem bypass, and we have couple of cases related to that fem bypass condition actually. We have to go for the forgot embolectomy in 2 patients when we have to go for the emergency fem bypass.
Okay.
I have 2 questions for Saem. As far as I know, you are going through the actually evolution of minimally invasive surgery. You have seen the starting and you are going through it. There are two problems normally faced. What are the difficulties you faced to come along this part? Number 1. Number 2, in cardiac surgery, re-exploration is a very common issue.
Yeah.
What are the challenges of re-exploration in MICS surgery?
Well, number 1, the challenges we faced in our journey, I think it should be answered by our beloved mentor. But the second one, I should comment about this. When there is a question of re-exploration, we usually, not only MICS CABG, but also the MICS valve surgeries, we first try to go for the same incision. And if you are capable to doing the surgery from that hole, the part are accessible to you through that hole. So the problems that arises, you have to manage that from that hole, it would not be that much of problem actually. We haven't faced any type of difficulties till date actually. And I think CM sir will answer the question about the journey.
Thank you. It's a nice presentation, but just a few questions from my side. Is there any structured, till now, is there any structured training program in your institute? As we know, NICVD is our parent institute.
Yes,
so my question to everybody who is working and leading in NICVD, because this is a very, what I say, high-end procedure in cardiac surgery. So are you developing any structured training program there? My second question, sorry. The thing is, definitely it's time-demanding procedure, but what is your protocol regarding if you have got a RV injury or immediate bleeding from the mammary, or if you see that when you are coming up there is distal bleeding, what are the protocols you follow? Thank you.
Okay, thank you, sir. I am coming from the second question actually. The first question will be answered by my mentor. The second question, the protocol is you have to go through the same incision, try to manage the complication. If not possible, then we have to go for the immediate median sternotomy. It is the protocol actually. We should not have to take any kind of risk regarding the life of the person. We have to manage it accordingly. If not possible through that hole, we have to open immediately. Thank you, sir.
Thank you for a nice presentation. My point of question is that what is your conduit policy in case of multivessel MICS CABG?
Okay, sir. Actually, we go for the lima harvesting for lima to LAD and diagonal if needed, diagonal sequential, and we go for the vein for the rest of the conduits, rest of the grafts.
So comment from the mentor of Dr. Saem.
Thank you for the questions. The journey is very long. We all know it very well. I will discuss it on later about the journey. I want to tell that soil by questions. Then already a society would workshop before COVID, but in COVID 2 years we have a pause. Then nowadays we are trying to do another workshop in minimal invasive NICBD. At the time we keep all the you notice through mail or phone, and you all can join it. Thank you very much.
Thank you so much for your nice comments.